Thank you. I'm happy to make this presentation on behalf of my colleagues in the HIV section. I'm Chewe Luo, I'm the chief of the HIV section, and I have a number of my colleagues in the room. So during the question and answer session, if I can't answer anything, I'll pass on to the right people to respond. I just wanted to start, first of all, by reminding us our commitments to the current strategic plan, which is really, we spelled out to improve access of children, adolescents, and mothers to HIV prevention and treatment interventions. And we have 6 outputs in the strategic plan that spans from working with communities to make sure that we create that demand for mothers, children, and adolescents to access services, but also working with government systems and also capacities to make sure that those services are available to the recipients that we are most interested in. And we also recognize that within the spectrum of things, we needed to make sure that we also focused on the most marginalized populations, because HIV also disproportionately impacts those populations, especially in some of the middle-income countries. And then finally, we were also working regionally to make sure that whatever lessons we learned at the country level could be translated. Now, I love to present this slide because I think everybody probably in this room realizes how much progress we've made, especially in the prevention of mother-to-child transmission. But I just want to actually highlight the fact that this did not happen by accident. I've looked at this data as far back as 1999, at a time when it was very clear that in the Western world, within 6 years, they were talking about elimination, because we found out in 1999 that giving antiretroviral medicines that normally we give for treatment of HIV to mothers could actually curb infection to babies. So we've known for a long time that antiretroviral drugs work for prevention. If you can remarkably reduce the level of virus in the mother, you can actually reduce transmission to the baby. And we knew that from the beginning. But it's not until 2009 when all of us got together and said, we have all this evidence, we know what to do, we have simplified platforms now to deliver to mothers. How do we move this to make sure we get the results that we want? So the schema that I have on top there was the whole effort around how do we make it simpler for mothers? How do we move the option B+, which is basically one pill, combined pill of several medications to mothers to reduce mother-to-child, but also keep mothers alive. And so we talked about really a global movement around simplifying approaches so that we could reach every mother in every part of the world. And the chart up there just tells you where we were in 2016, that over 88% of countries had adopted the strategy. So it didn't matter which part of the world you're in, simplification was the key to ending AIDS in children. And what I have at the bottom here are the priority countries that the progress that we made in the priority countries that we identified, where we said we need to go to those countries where most of the infections are happening. So what you have in the blue here is the progress we've made in the 21 African countries that make up over 90% of infection in babies. By 2015, and that data is actually improving, continuing to improve, we were reaching over 77% of women with antiretroviral treatment for their own health and to prevent mother-to-child transmission. What that means in the black is that going back to 2000, we've had a 70% reduction in new infections in babies. And that drop, 60% of it was since the launch of the global plan. So what this means is that joint efforts, collective accountability, governments in the lead, we can achieve results. The difficulty that we have is that we set our bar very high in terms of defining elimination. So when you look at the progress we've made and how many countries have been certified as having eliminated mother-to-child transmission, we have those countries there: Thailand, Armenia, Belarus, and these are the countries that have been WHO certified, and we celebrated them during the General Assembly on AIDS, the high-level forum on HIV. They were all here, and we're able to celebrate with them. But the issue is we're not quite there. So the game is not done. And I'll come back to this point as I continue with this presentation. Now, what I'm talking about in terms of progress, has not happened without UNICEF. So what I want to highlight, moving on from the progress on PMTCT, is the type of work that UNICEF has been doing. So first, I want to highlight the whole issue of adoption of option B+. UNICEF housed the interagency task team for the prevention of mother-to-child transmission on the elimination agenda right here at headquarters, which we were actually hosting that together with WHO. And with that, what it meant is that we had a coordinated effort with all partners, everybody, saying what tools do we need, how do we develop the capacities, how do we actually track the progress and the milestones around this. So that's the advocacy that we did, but underpinning that was also a lot of technical support that we provided. The second is that with the support from Sweden and Norway, UNICEF actually led some of the work to try and demonstrate the how to do it. How do we link facilities where these women were supposed to get their medication with the communities where they live to try and have that movement of the continuum of care from community to facilities and back to community. So with funding from Sweden and Norway, we were able to work in the last 4 years in a number of countries to try and define that community facility linkage system and what is it that needs to be done. And we're able to uncover a lot of things within that we're all working at community, but all from very different perspectives, and trying to harmonize that response and monitor how community actually interfaces with facility, and how do you monitor the impact of that when you look at the gains that we have, the 77% access to treatment. Adolescence is another area where UNICEF has been concerned, and we've put out several publications of the unfinished agenda, the lack of progress in adolescence. I just want to say, we presented last year that Mr. Lake, actually with Michelle Sidibe, the head of UNAIDS, launched a program which is called All In for Adolescents to end AIDS in adolescence, with 2 key targets. One is a 75% reduction in new infections in adolescents, 15 to 19, but also reduction in HIV-related mortality, because we reported last year the tripling of deaths in the adolescent age group, and that we needed to do something. What I want to highlight beyond the launch and our convening power around All In, and what we've had to do in terms of advocacy, partnerships, and empowerment of adolescents themselves to be part of the response, is that over the last 2 years, since 2015, we've been able to do 25 country assessments, because what we found is that part of the inaction with adolescents is that we just don't have good data for adolescents. A lot of the reports that we put out on adolescents have very scanty data, data that will not help you think about what are we going to do and how do we push the needle. So we've done 25 assessments, and the good news is, although the report is not out here, the report has been finalized around the 25 assessments. We finalized it at the end of December, and it is on our website for those that are interested. So the country assessment, and what that is doing is really translating the inaction into this type of support that we need. So for example, the Global Fund has just increased its allocation to adolescents in its country programs of support. And they're working country by country in 13 countries to make sure that we have enough resource allocation to this particular age group to have impact. Finally, I want to talk about innovation. We can't do this in children, we can't do this in adolescents without innovation, and I highlight 2 here, but there are a number more that we've been involved in, including how do we use SMS platform to link adolescents and how that communication happening. But part of the response to adolescent treatment, pediatric treatment, is that working with UNITAID, we have funding to actually advance deployment of new technologies that can be deployed at the point of care, like we've done for mothers, for us to make a diagnosis in that infant for timely initiation of treatment and also switching of treatment. The other innovation that I want to highlight, again with UNITAID, is the issue of adolescent prevention, and within that, we're working in a number of countries to try and advance delivery of antiretroviral treatment to adolescents for prevention. And so that's another innovation that we're looking at on the how to do it. So all this, I've just highlighted a few of our partners, and I've talked to them as I'm talking. And so these are some of our partners. But what I want to highlight is that the leadership that UNICEF has provided and the advocacy that we continue to do, I think has yielded results for us, and we're very excited that now, coming out of the high-level forum on HIV/AIDS, we launched a new initiative which is being called the 3 Frees framework. Start free, AIDS free, stay free. And what this means is that we're not just focused on preventing infections in babies. We're also saying we start free by preventing infections in babies, but we keep these children alive through adolescence by keeping them free of HIV, so stay free. And then for those that do end up getting infected, we also say we don't want any child dying of AIDS, child or adolescent. So the AIDS-free agenda is making sure that treatment access is a reality and maintaining these children on treatment becomes a reality. So this is the 3 Frees framework, and it's a very bold agenda, very much aligned to the fast-track strategy of UNAIDS, where we're saying we're going to end HIV by 2030. For children, we're saying no. We have to end AIDS by 2020. So we have a super fast track within the fast track that is focused on children. And this framework really makes a lot of sense for us, for UNICEF, because we're bringing everything together from a life cycle approach. So these are some of the results, and just to highlight why the 3 Frees framework is so important, and it's really to illustrate that despite the progress that I talked about in preventing mother-to-child transmission and making sure that pregnant women have access to ART, the access is disproportionate. You can see there that in Africa particularly, when you look at Eastern and Southern Africa, we're talking about 88% access. But when you go to West Africa and Central Africa, we're talking about 45%. So that inequity is something that we need to work on. When we look at countries, again, in the green, I highlight where we are. Although we only have very few countries that have been certified as having eliminated, we know that 6 countries in Africa have more than 90% access to ART, and we have an additional 6 countries that have more than 80%. So the unfinished agenda for us is to get some of these countries to the finish line to be certified as having eliminated mother-to-child, because we can do it. And the next issue for me is around children. So we're reaching all these mothers, and for me, it pains me to see that 80% access in mothers, half in children. So the critical question is why? And I've talked to some of this. We still don't have good diagnostics for children that can be delivered at the point of service for that early initiation of treatment. The other thing is that we don't have good formulations, especially for the youngest infants, for them to be initiated on treatment. The second point that I want to mention is the adolescent prevention agenda. We still have too many infections happening. As we sit here, every 2 minutes, we have a new adolescent infected with HIV, and that is unacceptable, and we continue to work on this. What is actually challenging for us is the youth bulge that is expected, especially on the African continent. We've applied that analysis across the globe and also Eastern and Southern Africa, West Africa, and we're saying if we continue business as usual, we're gonna see many more infections in adolescents by 2030. And so we have to change course. So lessons learned, I just want to say that, and I think I've highlighted the fact that we've made it for mothers because we've made it simple. So simplification is the key. A public health approach to any of these things has to come with new solutions. The second is, I've talked about the youth bulge and also adolescents infections rising, but I want to also turn this into an opportunity. We've really created the momentum with the all-in agenda, especially at the country level. Multiple sectors are working together to try and look at the data together and come up with holistic approaches to impact HIV. And I think that momentum can be used as an opportunity for building programs. The third thing that I want to talk about is integration. Now, everybody talks about integration, and we all want to do it, but it comes with its own challenges, system challenges for you to do it right. So we're talking about integration with accountability is critical. The next question is, how do we do that effectively? My colleague here talked about the major killers of children. He didn't even talk about HIV. And it's true that HIV is not number one or number two, but it is number one maybe in adolescents. And so when we expand our focus, when we start to look at inequities, when we start to look at what might enhance your program, who are those children who are dying despite immunization, despite your amoxicillin, we can have a different storyline. HIV still kills children, and it's still killing children, but we can do something about it. The final thing that I want to talk about, our resources are rapidly diminishing, and I want to come to the resource envelope. Now, this morning, you heard how the least supported program in UNICEF in terms of where its money is going, where the money is being mobilized and where you want to spend the money that you're giving to UNICEF, HIV is the least supported in that paradigm. What worries us working on HIV is the schema that you see on top there that we are continuing to have declining resources. And it is at a time when you know that UNICEF work on HIV is part of a broader agenda within the UNAIDS joint program. And as we sit here, we've been going through a reform process within UNAIDS where the donors are saying, what's the value of the jointness of this program? What are those results that you're achieving jointly? The sad thing that has happened is that within that conversation, there is an acceptance that we should continue supporting the AIDS program. Nobody questions that. But what has come with that is prioritization of where the money goes. And for UNICEF, we've had an 80% cut to our UNAIDS funding to UNICEF. And that worries us in terms of some of the things that we've achieved and how we're going to move forward. The good news is that HIV continues to be an SP priority and has results at impact level, outcome level, and output level. And for me, that's really important because it sends a very strong message, and hopefully we can work together on how to sustain the UNICEF HIV program. So finally, it's about the future. I just want to say a few things on this. We will continue to integrate, we will continue to innovate, we will continue to work on including and leaving no child behind on HIV. And within that, we're talking about the unfinished agenda of mother-to-child transmission, eliminating mother-to-child transmission, eliminating the pediatric and adolescent treatment gap, but also eliminating new infections in adolescents. And we've been working since last year, as we've been grappling with the funding situation, to see how is UNICEF going to be most effective in doing this. And what I want to end with is that we have decided to have a differentiated response. We're not going to do everything everywhere and anyhow. And you can see that based on the epidemiology, based on the strength of the systems and the capacity of government, based on whatever else is going on in terms of investments in that country, we've actually decided as UNICEF that for some countries, we'll just be tracking the progress and drawing attention to countries to do more. For some countries, we're going to just do targeted programs where we see critical gaps. And there's 35 countries where we still feel UNICEF needs to have an intensified response to get the countries to the finish line that is ending AIDS in children. So thank you.